Do I have to move closer to it? Okay, hey everyone. So sorry for the delay. I was a little bit sick yesterday, but I'm back now. Today we're going to do the lower limb revision lecture. We're going to cover key structures, bony landmarks, bones, vessels, and nerves. Actually, we're not going to do that. PS Panda has done a really good anatomy lecture. I don't really have the time to explain all the muscle groups, bones, and nerves to you, but they've gone and done one that's absolutely clutch. What we are going to cover today is just some clinical content, and hopefully through that you'll inadvertently learn some anatomy on the way. So we're going to start from the very top, starting with pelvic fractures. So the pelvis is made from the ilium, the ischium, and the pubic bones, as well as the sacrum and the column. So there's two types of pelvic fractures, stable and unstable. Have a look at these two diagrams, and I'm going to give you about maybe like 10 seconds just to guess which side is the stable and which one side is the unstable fracture. Do a little countdown, like 10, 9, 7, 8, 7, 6, 5, 4, 3, 2, 1. Anyway, okay, so the stable one is the one on your left, and the unstable one is the one on your right, which you can kind of tell because the unstable ones kind of look just more severe in general. And why do we care about this? So in the stable fractures, we have often only one break in the pelvic ring, and the bone ends up lining up quite nicely, and they're often from low energy fractures. So the unstable ones usually have 2 or more breaks in the pelvic ring, and the ends of the broken bones don't line up correctly, so they need more surgical intervention. And this type of fracture is more likely to occur due to a high energy event. So why do we really care about what a high energy event is? Well, high energy traumas usually result from something like a car or motorcycle collision, a crush accident, a fall from a significant height, and depending on the direction and the magnitude of the force, they can be life-threatening and require surgical treatment. So your approach about it is completely different than a lower energy fracture, which is something due to bone insufficiency. So that's most likely due to someone who is older with osteoporosis, who just takes like a minor fall while they're standing up. So one has the higher energy trauma has a higher likely chance of having severe bleeding and needing to have like major surgical intervention, whereas bone insufficiency, you're looking at surgery as well, but also more chronic management of osteoporosis and other symptoms from that. We're going to move a little bit lower now to femoral fractures, or most likely neck-femur fractures. So from the most to least severe, there's 3 types of neck-femur fractures. There's a subcapital, which is under the head, transcervical, across the neck, and intertrochanteric, which is across the greater and lesser trochanters. And why do we care about this? Well, neck-femur fractures have a high risk of avascular necrosis because there's only one single blood supply to the medial circumflex artery. So this is kind of your anatomy for you. So the medial circumflex artery is off the profunda femoris artery. When you break the neck of the femur, there's a larger risk of increased displacement of there's a larger risk of avascular necrosis with displacement of a femoral head. And how we know something is a neck-femur fracture is because it usually presents with a shortened thigh due to the contraction of the quadriceps, with the hip externally rotated. And the main demographic for these types of injuries are women with osteoporosis. So here's a little case for you. Oh, oops, I ruined that. How do I go back? Let's just pretend that didn't happen. A man was drunk and decided to climb a structure in an attempt at parkour. He lost his balance and fell to the ground, hitting a pole on the way down. His equally drunk friends hear a snap, and he presents the emergency with a severe pain in his right thigh. He soon becomes pale and hypertensive with a rapid pulse and a swollen thigh, radiology shows a mixture of femoral fracture. So which of the following vessels are likely to be severed? Pretending that I didn't just show you the answer, think about your anatomy. Think about the main arteries that we just talked about in the femoral, in the neck of femur fracture. The most likely one that he would have gone and severed is the profunda femoris artery. Again, this is inadvertently learning your anatomy. Femoral fractures, we know, are very common in drunk people falling from great heights because they're blunt trauma, they're often stress fractures, they're high impact injuries that lead to straight spiral or comminuted fractures in the young. They're particularly prevalent in the young and the elderly, but you see a lot less neck of femur fractures in someone who's going to be going out and getting drunk and jumping off a tall structure because they normally affect older gentlemen or ladies with osteoporosis. And we really want to treat neck of femur fractures because if you don't, then they end up immobilized, and there's a lot of complications coming from that. So there's a lot of DVT problems. I think if you leave a neck of femur fracture untreated for a month or so, the likelihood of death is like 80% or something in a nursing home. So it's something that you really want to prioritize really quickly once you get out into the clinic. So back to the femoral fractures, what is endangered during a femoral fracture is the profunda femoris artery and its perforating back branches. So you want to be really careful of the femoral artery because that's 25% of your cardiac output, which would explain why the patient before is pale and really hypertensive with a rapid pulse. And you want to be careful because any further bleeding in that area or just damaging that area in general can lead to sciatic nerve damage, which leads to more proximal and distal, which is more common in proximal and distal injuries. So when you're diagnosing a femoral fracture, you want to be looking for the 6 Ps, which is pain, pallor, paresthesia, perishingly cold, pulselessness, and paralysis. You'll notice muscle infarction, and it's usually treated with a fasciotomy. Again, like I mentioned before, you need to be really careful of these types of fractures because it can lead to compartment syndrome. So what is compartment syndrome? Compartment syndrome is swelling within a fascial enclosed muscle compartment in the limbs. It's typically caused by limb trauma, intracompartment hemorrhage, and limb compression. And this is really important because as pressure increases, capillary blood flow and tissue perfusion is compromised. So that leads to a lot of neurovascular damage if it isn't treated. Here's some anatomy. If you're looking at kind of the thigh area, we have 3 compartments, so anterior, medial, and posterior. When you're kind of looking at compartment syndrome in the thigh, it's most likely going to be in the anterior region because that's where all the major blood vessels are. It's a completely different story once we get into the lower limb, where we have 4 different compartments, so the anterior, lateral, superficial, posterior, and deep posterior. There's a lot more places for that to go wrong, but normally when we get compartment syndrome in there, it's behind the gastrocnemius and the soleus muscle. You can have a look at these diagrams if you want in spare time and just go through the individual muscles there. So we'll move on to something else. A patient presents in emergency with an internally rotated, adducted, and flexed leg with their foot being, okay, I did a lot of typos on this, with their foot being towards the middle of their body. The sciatic nerve palsy is present, and it is later confirmed that they were involved in a car crash where their legs took the brunt of the impact. Luckily, radiology confirms that there are no fractures in their legs. What is most likely wrong with them? So you want to be thinking when you're looking at this about the placement of the leg, what that kind of indicates. So if you have their foot being towards the middle of their body, adducted with their flexed leg, and then the hip kind of popping out as a result of that, it's most likely going to be a dislocation of the hip joint. This one is presenting as a posterior hip dislocation, which is the most common type of hip dislocation. If you think about just the way that your hip is constructed, I guess that makes a lot of sense, you're not really going to be falling backwards, pushing your hip bone forwards. It's more likely going to be like you land on your legs and it pops your hip out posteriorly. But anterior dislocation does happen. That presents here as something that's externally rotated, adducted, and mildly flexed. So on this side. A lot of problems with this is avascular necrosis again. And as mentioned in the case that we just looked at, it causes a lot of palsies in that area. So a way to test dislocation of the hip and any other hip pathologies, I guess, is to learn your hip exam specifics. So I do it by the PMS kind of, I don't know, what do you call it? Acronym? No acronym, I don't know. So palpate first, you move, and then you do special tests. So you want to be feeling for the ASIS, iliac crest, iliac tubercle, piscis, I don't know, gradus trochanter, your pubic tubercle, your pubic symphysis, and your ischial tuberosity. Those are the really important ones. And when you move it, you want to do passive and then active first. I used to do active first and then passive because in my head I was like, oh, well, if they can't move it actively, then you go in and test passively. But oftentimes, if you do it passively, it's much better because if they come in and try to move something actively, it will hurt and they'll stop, and then you'll assume that they can't move it any further. Well, in reality, they can. They just don't want to because it hurts. So that's the kind of logic between doing a passive movement and an active movement. So you have your degrees of flexion and extension and abduction and adduction there. Try to memorize those. You will have to tell your examiner that during your OSCEs or your TSSEs, as they call it. Keep in mind of the special tests that they do as well. So the true leg length and the apparent leg length, and then the Thomas tests. A really good one when you're studying this is to go on medgeeks.com and brush up on your OSCEs. They recommend that you do everything from Tally O'Connor, but MedGeeks works pretty well as a study guide. So moving on from your hip, I guess we'll go a little bit lower and we'll go into vasculature. We're going to break things up by doing a little fun did you know? Did you know that Angelina Jolie chose to receive varicose vein treatment for her arms before her wedding to Brad Pitt? And they got this divorced anyway, so I guess that wasn't
pointless.
Yeah, it was pointless. But it does bring us to the next point of varicose veins and what the difference between varicose veins and deep vein thrombosis is, because they both involve veins, I assume. And the difference really lies in whether it's superficial or deep veins that are affected. So you can learn that graph in your own time, those diagrams in your own time. And again, it's more anatomy that we don't really have the time to go over, but pretty much varicose veins is superficial. It's just from the elasticity of your veins pretty much giving out, so the blood just kind of like pulls in. It looks a little bit ugly, but it really doesn't affect anything in the long run. DVTs are the ones that we're more concerned about in the clinic. So deep vein thrombosis are people who have just had surgery. They have long periods of inactivity. They affect people with inherited thrombophilia. They're more common if you're pregnant, taking oral contraceptive or HRT, hormone replacement therapy. You'll get to that when you study menopause. They are of a higher weight and they smoke and they're of a high age. So a treatment for DVT is a compression stocking, a heparin injection. Those are they're more common. Heparin injections are more common in the hospital. For just management, self-injections, we use a low molecular weight heparin, so that's enoxaparin, and then now they're kind of testing these like oral anticoagulants, which in theory, they have a better compliance rate because you're not injecting them compared to a low molecular weight heparin, but they don't. I don't know, the effect, there hasn't been enough clinical trials yet. That's not really important. My whole point is try to go on the Pharmacology website and read through the mechanism of actions of these drugs because they're quite important to not only the management of deep vein thrombosis, but also just cardiac events and stroke. Why is vasculature so important? Well, we've done veins, but now we're going to do arteries. The deep and inferior to the inguinal ligament is the femoral artery and the vein, and it's really important in the clinic because that's how you do a lot of catheterization when you're addressing cardiac events. So many procedures involve the femoral artery and the vein. They go through the inguinal canal, so like right near the crotch, and then they place it into the femoral vein, and from there you can go up all the way into the arch of the aorta, into the coronary arteries to perform any angioplasties or angiograms. The veins as well, you can put a catheter in there and they'll go into the renal veins, the gonadal veins, the right atrium and the right pulmonary arteries, as well as the superior vena cava and other great veins of the neck. So that's really important, just to know where all the major arteries go and how they interact with each other. Michelle Lazarus loves driving that one home. If you have time, try to look at what blood supply you use when you're in the womb. She loves that one. We'll move on to some more clinically relevant stuff. A patient presents with positive Trendelenburg test. What is the clinical significance of this and what does it look like? Okay, so here's a diagram of a positive Trendelenburg sign. Lots of dysfunctions can produce a positive test. So it's usually the weakness of your gluteus medius or your glute minimus. It shows hip instability. It might be an indication of osteoarthritis. People who have gone total hip replacements before they go through physiotherapy and before they're fully healed, they might show a positive sign for this. And it shows, most importantly, when you're testing this in a neuro exam, it's an indication of superior gluteal nerve palsy. The clinical bottom line is that this isn't enough to really diagnose anything, but it's a good indication that you need to have further tests on either muscle weakness or nerve damage. Some other tests that you can do in the clinic and that you should be familiar with is the Braggart test, a finger-nose test, not finger-nose test, but the toe-finger test, finger-toe test, Loughman test, Lysagh's test, McMurray's test, Romberg's test. Look all of that up in your spare time. They're really quite important, and they'll be in your clinical book. They love to stress that one in your CSSEs, especially I think the knee tests are really, really important, just because a lot of things, as we'll cover later, go wrong with your knee. We'll switch things up a bit by doing another, multiple choice question. Connor suffers from incontinence, and a few days after an accident, in addition to a recent onset of numbness in the saddle region, and he cannot have sex with his boyfriend because we are woke queens here. He has a worsening back pain, and that is rated an 8 out of 10. Clinical examination findings include decreased bilateral knee and ankle reflexes. So what is the most likely cause of his symptoms? Now think about it really carefully. The most kind of one that the point that I would like key in on here is numbness in the saddle region, because that indicates that there's problems with his L1 and L2, because those are the regions responsible for that, your saddle region. So that means it's most likely going to be Corda-Quina syndrome. Corda-Quina syndrome, they like to talk about this one a bit, presents as severe back pain, saddle anesthesia. So here, and you can imagine from the front what that would look like. Bladder and bowel incontinence, sciatica type pain, weakness in the lower limbs, absent reflexes, and erectile dysfunction, which I guess is an absent reflex, gait disturbance. So most of the time this is caused by inflammatory conditions or trauma. Spinal stenosis, we haven't really learned about, but most of the time when you're doing multiple choice questions, they'll either say trauma or inflammatory conditions. So like I said before, this is because of damage or inflammation to L1 and L2. So these are the lower motor neurons that branch off the spinal cord and travel inferiorly into the meningeal space. That's why when we do lumbar punctures and spinal anesthetics, we go below the level of L1 and L2 just to avoid all of the signs and symptoms that we mentioned here. So next one. A patient requires their drugs to be administered intramuscularly in the gluteal region. What is the safest place for this type of injection? So you want to be thinking about where your nerves are, well, where your major nerve is in that area. So the sciatic nerve, where that passes through in relation to your gluteal region. You can't do it too low down because that's when the sciatic nerve comes out. And you're wanting to do something quite superiorly, just to avoid all of the major nerves and vessels that enter the gluteal region above the piriformis. So that means when you do an intramuscular injection in the gluteal region, you're going to be aiming for the upper outer quadrant of each gluteal region. You can see the area indicated in red. That's where the safe injection site is. Like I said before, it avoids any back, any nerve injuries, and the needle should enter the gluteus medius anterior superior to the margin of the gluteus maximus. Pretty much you're just feeling for where the axis is and working it from there. What are the most common sites for muscle injury in the upper and lower leg? So when you're thinking about questions like this, think about what muscles you're going to be using when you're doing high impact or explosive kind of movements. It won't be anything from the anterior side, because you don't really, I guess, jump off of those muscles. You're more looking at the posterior compartments. So if you talk to athletes, you'll hear a lot of them talk about how they put a hammy. So your hamstring muscles are your semitendinosus, your semimembranosus, and your biceps femoris. So that's majority of injuries to the upper lower limb, I guess your thigh area. For tears below the knee, it's typically at the soleus muscle, although other muscles may be affected, just because the impact of your movements are a lot more balanced between your lower leg muscles, like your lower leg muscles, compared to your upper lower limb, which is mostly done by your hamstrings. So now that we've covered muscles, I think we'll move on to the knees. So, fun fact, this is the Strokes album cover. When it first came out, people thought it was a butt, and then the quite popular urban legend is that it's actually a picture of a leather glove on a knee. But I don't know whose knee looks like that.
I have not seen the knee.
Yeah,
like that, no.
So that is definitely not a knee. Just a fun fact about butts and knees. When you're doing your knee exam, again, do the PMS. Palpate for your joint line, your femoral condyles, tibial tuberosity, borders of your patella, just like jig it around a bit, hamstring insertion, popliteal fossa, and you're looking for Baker's cyst and popliteal pulse. That's a really important area because that's where all of your anastomosis and your major vessels are. And then move it passively and actively. Special tests in this area are your patella tap tests, your bulge signs, your stability of the ligaments there, anterior and posterior draw tests, varus and valgus tests, and then the McMurray's tests. Why is this area so important? It's because the knee is particularly susceptible to soft tissue injuries just because of the nature of the movement around that area and where all the muscles and vessels attach to. So when you're doing all of these knee tests in the knee exam, You're looking for you're looking for ACL, PCL injuries, meniscal tears, trauma to the collateral ligaments, and most of the time when you're diagnosing these conditions in a clinic, it is not uncommon for multiple injuries to occur together. So if they test positive to, say, an ACL or a meniscal tear, they're most likely going to have an injury, another type of knee injury as well. And that's just, again, due to the nature, I guess, of movement in the knee. So why this area is so important is because any injury may involve the neurovascular bundle. So the burovascular bundle. The neurovascular bundle. So assessment of the neurovascular structures is absolutely critical. As you can see in this photo, there's a lot of vessels and anastomoses that run through the area. Again, like I mentioned before, a really important area that you need to get familiar with is the popliteal fossa, popliteal region. The borders are superior medially at the semimembranosus, the biceps femoris, the medial head of the gastrocnemius, and the lateral head of the gastrocnemius. And in there, you can feel for the popliteal artery, the popliteal, well, you can't really feel for the popliteal vein, but it's near the popliteal artery, and then the tibial and common fibular nerves. So a popliteal aneurysm occurs when there's a dilation of the popliteal artery, and that will compress on the tibial nerve. It will lead to a lot of pathologies and palsies in your feet and your lower limb. So, next one. A patient presents with ankle pain after a sporting injury. They claim to have felt like their ankle was being shot. Their history reveals that they are quite healthy. However, they had recently used antibiotics belonging in the quinolone group. What is the most likely diagnosis for their ankle pain? So right away, the kind of thing that gives them away is that they describe their pain being like a shot, or if someone comes in with a similar presentation, they will say something like, it felt like they were getting kicked in the ankle. And the most likely diagnosis for that is, I think you probably gathered, the Achilles tendon rupture. So like I said, it's a pretty straightforward diagnosis. If they complain of that kind of pain, that's usually what it is. It will reveal like there's a gap in the tendon, in the Achilles tendon. Being on, I don't know why, being on the quinolone group of antibiotics increases your risk of Achilles tendon rupture. However, most of the time, people who are coming in with this type of injury are athletes who just like did it spontaneously. And if they've done their Achilles before, that's pretty much, you can't really ever fix it properly again. So they're at a much higher risk if they've already had their Achilles ruptured before. While we're on the subject of feet, I guess, we'll move on to the next question. A doctor is examining a diabetic woman with peripheral neuropathy and is trying to recall his dermatomes, which nerve innervates area 10. His or her dermatomes, because we all work queens in here. So the answer for this is your saphenous nerve. Try to get familiar with your dermatomes. They really like to test this during CSSEs. There's some really good YouTube videos of the dermatome dances. But yeah, once in your own time, have a look at that diagram and familiarize yourself with it, because it's quite important during your exams. We don't really have time to go into that today. A 30-year-old has a laceration along the sole of the foot. A nerve block is being put in prior to surgery. Which of these nerves should be blocked? So again, refer to this diagram. What nerve should be blocked? So in order so they don't like feel the entire foot. And if you look on this diagram here, you see that predominantly, well, the nerve that supplies like the foot area is the tibial nerve. So that's the one that we're going to block before surgery. And we kind of covered this in the cauda equina question, but what level does the adult spinal cord end? So think about what level we need to be under when we're doing like a spinal block. And that's L1, L2, again, just to avoid all those problems that we talked about in cauda equina, which is saddlebag numbness. Dysfunction. What is a talus fracture and why is its management so important? So we've moved down all the way to the foot now. I'm going to give you like a few seconds to think about what talus is. So just a little refresh. That's a bone in your ankle or your foot. So it makes up the lower part of your ankle joint, with your tibia and your fibula making the upper part of your ankle joint. So the talus sits above the heel bone. If you remember what the heel bone is, it's your calcaneus. And together the talus and the calcaneus form the subtalar joint, which is really important for walking, especially on uneven ground. It's what kind of gives your foot that ability to like balance. So like we talked about, the talus is the main connector between the foot and the leg. It helps you transfer your weight and pressure forces across the ankle joint. And as a result of that, it is very susceptible to fractures, especially from high impact or landing funny. A lot of people will come in with a fracture to the neck of the talus. And why is this so important? It's because the main blood supply to the bone enters the talus via the tarsal canal from the posterior branch of the tibial artery. And then the branches of your dorsalis pedis artery enter the superior aspect of the talar and supply the dorsal portion of the head and the neck. And then the branches of your fibular artery supply a really small portion of the lateral talus. But this is really important because when you break the neck, you are interrupting that blood supply. A break means that it's really likely, if you don't fix it properly, to end with osteonecrosis. So that leads to premature osteoarthritis, and it will require extensive surgery later on. That's a summary of the information I just talked about. Talus fractures are broken up into, by the Hawkins classification, into 4 types. So type 1 is least severe, type 4 is very severe. Any fractures to the neck, you're looking at surgical repair just to make sure that all of those vessels are going to be okay. So we talked about how a result of a talus fracture is osteonecrosis leading to osteoarthritis. So I guess we really need to talk about treatment for osteoarthritis or osteoporosis, actually. Let's talk about osteoporosis. So osteoporosis is just bone insufficiency, pretty much. It happens to a lot of older women because once you reach 30, women stop absorbing calcium from your diet, and then once you hit menopause, your bone density just goes straight down as a result of drops to estrogen and other types of hormones. So before treatment of osteoporosis, consider whether osteoporosis is caused by hypothyroidism, or just any hormone imbalances, really. Your treatment for it is, for women especially, is estrogen replacement therapy. We try to avoid that a little bit because there's an increased risk of breast cancer, deep vein thrombosis, and cholecystitis. So here it says a rankle, INKL. If you're not sure what that is, it's just a gene that it's an apoptotic. Yeah, that word, gene. So it regulates just how fast your osteoblasts die, pretty much. So you're trying to, so selective estrogen receptor modulators like relaxin targets that gene. It doesn't have the same side effects as estrogen replacement therapy, but there's still a risk for deep vein thrombosis, which, as we talked about before, leads to an increased risk of stroke or cardiac events. There's also alendronate, which is first-line treatment right now for osteoporosis because it inhibits formation and activity of osteoclasts by deposition in the bone matrix. Problem with that is that you have to drink it first thing in the morning with a full glass of water and then just stand for 30 or 60 minutes. So it has really bad compliance. You don't really need to know too much about monoclonal antibody therapies. We don't really cover that. If you're more curious about the mechanism of action of these types of drugs, go onto the ePharmacology website. That's really good. They also have bone anabolic agents as well. Human parathyroid hormone activates osteoblasts more than osteoclasts, which increases bone mineralization. But the problem of that, when you're activating something like much faster than it is intended to be, it leads to an increased risk of cancer. We talked about kind of muscle injuries before and other, I guess, pathologies in the lower limb. And the treatment for a lot of those bone injuries, other than like major surgery, if you damage it really badly, is just to rest it and to use NSAIDs, so non-steroidal anti-inflammatory drugs. You can kind of have a look of their mechanism of action in your own time. This is like 3 active learning sessions and like 2 lectures, like summed up right here. But pretty much it targets the formation of it targets prostaglandins, or the formation of prostaglandins, which stops inflammation, and some kind of helps stop clotting. But if you want to stop clotting, you're using like something like a heparin or anticoagulant. Some common non-steroidal anti-inflammatories are, you probably know of these ones: ibuprofen, aspirin, diclofenac, Celoxib, I don't know. A lot of them have side effects, GIT side effects. So you have to keep, I think with ibuprofen, you've got to keep it under 4,000 milligrams in 24 hours, no more than 1,000 milligrams per dose. Otherwise, it leads to a lot of problems, such as ulcers in your stomach lining, nausea, cramps. I think for some people, it lead to constipation as well. And you have to tell your patients to be a lot more careful with these, especially if they're drinking. I think the general rule is whatever is safe to have in 24 hours, so 4,000 milligrams of ibuprofen, you have it if they're going to be drinking that day, so 2,000 milligrams in 24 hours. Contraindications are obviously allergy, 3rd trimester of pregnancy, and if they're already on a diuretic or ACE inhibitor, because it will lead to severe kidney damage. Moving on, there's also other analgesics that you can have a look at in your own time. Opioids, steroidal aids, local anesthetics. They're all kind of something that you don't really want people to be self-administering at home. Opioids are more common, I think, for hospitals. And then you don't want anyone to be on steroidal anti-inflammatories for any longer than a couple of weeks at a time, because it leads to a lot of other side effects. So just keep that in mind when you're treating. What am I doing? Okay, so gout is another condition that affects your smaller joints, so usually your toes and sometimes your ankles if you're really unlucky. So it's a deposition of uric acid in your joint capsules. They don't really know the exact pathophysiology behind it, but they believe it's an autoimmune condition where your lymphocytes infiltrate the joint space and destroy the uric acid crystals, causing inflammation. And again, go on ePharmacology, look at your gout medication in your own time, because there's a bunch of contraindications to gout medication. Okay, rheumatoid arthritis, that's another thing that really impacts on your toes as well. So it's an autoimmune inflammatory process which affects your joint capsules mainly, and it's a type 4 hypersensitivity reaction mediated by T cells. Again, that's a really complicated lecture that we don't really have time to go in for right now, but pretty much just know that it's an autoimmune condition, and it causes your joints to become swollen, tender, and warm with stiffness and limiting movement. So kind of what differentiates it between other forms of arthritis is that it usually presents as morning stiffness. So it doesn't really, it lasts longer than an hour, and it will get worse when you don't move it. Unlike osteoarthritis, it's normally your fingers and your toes and your small little joints like your wrist bones instead of like your hip, like osteoarthritis. And it's bilateral instead of unilateral. The treatment of this, you can get a lot more complicated with it, and again, go on Pharmacology and have a look. But to summarize, use a high dose of methotrexate with folic acid supplementation and prednisolone and non-steroidal anti-inflammatories when needed. Again, you want to make sure that you're not using this chronically because it will lead to a lot of issues. And amongst the elderly, which is where most people have rheumatoid arthritis, most likely they'll have another pre-existing condition which requires them to be on a diuretic or an ACE inhibitor. So try to limit Panadol, ibuprofen, or aspirin usage in these groups. So again, look at this in your own time because it is quite a bit to remember. So we've gone all the way from the pelvis, down to your thigh, your knee, your ankle, and we've done feet and your toes, so rheumatoid arthritis and toes. That's pretty much the entire lecture. Some further resources, I've harped on about it enough, but use ePharmacology. I didn't use it in my first year, and I was an idiot. I was so stupid because it's actually so helpful. They have a tendency in a lot of year 1 lectures just to throw a heap of drugs at you, because they like to justify all 3 years of their PhD, which they spend learning about that drug. But a lot of them aren't relevant, and a lot of them you will forget about. The ones on ePharmacology are your core ones that you will need to know. And once you kind of understand the mechanism of action for them, they're not easy to remember, but they're useful. If you can't be bothered reading Tally and O'Connor, use medgeeks.co. They provide really good videos based on your OSCEs. Just when you're using that though, because they are based in Britain, they do things a little bit differently. So you always want to be referring back to your clinical handbook as well, just to double check that you're not learning anything that you don't need to be learning. And then I mentioned them before, if you want a more in-depth cover of anatomy, which we didn't have time to go into today, check out the PS Panda lower limb anatomy presentation that they did. That one is pretty clutch, and they go into a lot more detail. Other than that, that's the end of the presentation. I hope you learned something. If you didn't, I hope that you learned that Angelina Jolie got treatment for her varicose veins. Cool.
Thanks so much, Yaya. I think one of the questions a lot of secondaries get asked is how do you learn anatomy? Because obviously we get a lot of content thrown in our face, and it's been pretty poor this year because they have, for Upland, they didn't even have a lecture. They didn't have any lecture content for anatomy. So what would you suggest as to how they could learn all of that nitty-gritty stuff?
Okay. So a lot of people in our year draw these really complicated diagrams of like muscles, and they're like picture perfect, but they're absolutely useless. You will learn like almost nothing from drawing unless like you're one of the like 1 or 2 people who can actually draw, and it's fun for you. In which case, congrats. What I recommend is flashcards. Netters has really good ones. Grey's Anatomy has really good flashcards that have like clinically relevant stuff in them. That being said, sometimes they go too in depth if you buy them yourself. So I don't know if anyone's told you about it, but Anki, which is like a computer flashcard program, that's really helpful for making anatomy flashcards, because if you don't know something, you go through the flashcards pretty much, and then you rate it based on how easy it was. And if you find it really hard, they'll show it, it'll come up more in your deck, and then you can just revise it throughout the term. So anatomy is a lot about like exposure to it. In terms of just learning the basics, and not getting too confused by the textbook, there's a website called wesnorman.com, W-E-S Norman, Norman.com, which I use a lot. It's some like old dude from like the early 2000s, but he's like really simplified down everything to just the stuff that you need to know, because I think a lot of the times when you're doing anatomy, they throw a lot of like niche stuff at you, which is really great and all if you've got the basics pegged down, but it's really confusing if you haven't had an upper limb like lecture and you don't know like the basics just yet. So try to get on like a website like wesnorman.com, or I think there's like Learn Anatomy, or like Anatomy Makes It or something, where they just give you like the most basic stuff, which is like, here's one bone, here is another bone, this is how they join. You're like, this is so stupid, how am I ever going to learn anything with this? But yeah, you learn the basics and then you can add to it with like all the niche stuff. I hope that helps.
Absolutely. And correct me if I'm wrong, but muscle attachments are the most useless thing I've ever learned. I spent so much of first year just learning, oh, this attaches here. And you don't get any questions on that.
No, I think the only one that they really ask that's like kind of like about a tendon is like your Achilles.
Yeah.
So, like not really. Like everyone knows what an Achilles is. And yeah, I don't remember. I don't remember my muscle attachments.
Yeah, no, neither. And also, as you have mentioned, the Grey's Anatomy flashcards are apparently really, really good. And don't take my word on this, but some people have told me that Monash actually uses some of those scenarios word to word in the exams.
They're like 100% do.
Yeah. And you never see them in any of the papers because they always redact the questions, so just they don't get exposed. So that's pretty good. And also, if you do like Ankis or use them, we do have a deck specifically for Monash medicine first year, second year, semester wise. So that's something which a lot of people find really helpful.
Is that the one on the MUMUS drive? And they've broken it down.
Yeah.
That's really
so it's week by week. And if any of you kind of really want that, feel free to get in touch with me. I'll be more than happy to kind of have that set up. Thank you all for coming. We'll have I think one last round of in-sem revision lectures. That'll be your cardio, a bit of immuno, as well as a bit of pharm. And that'll be a wrap for first year. So thank you guys so much for tuning in. And again, if you have any questions, feel free to contact Yaya or me, and we will be happy to help. See you guys.
Bye.